welcome to a new episode of Retina Chats. I'm Mohammed Ghunaim, and with me Dr. Mustafa Al-Manhali.
Hello, everyone.
So today Dr. Mustafa will present his case. So tell us more, what's going on here?
So this is a 72-year-old male pseudophakic in this eye, and he presented with retinal detachment, a rhegmatogenous retinal detachment. And he was planned with for a scleral buckling,
Okay.
but due to his poor general condition, he was on anticoagulant, and he was referred to his cardiologist to
Assess if you could have the
Yes.
general anesthesia.
and he postponed this patient for 1 week.
Okay.
He presented later on with some vitreous hemorrhage, painful eye, and more hypotenuse eye. And on assessing this eye before entering to a scleral buckle, we found that this patient is presenting with a choroidal detachment as well.
Okay.
So the decision was changed to vitrectomy instead of scleral buckling. And the challenge in the beginning of the surgery was to place the trocar, and as we can see, the trocar was introduced in the site of the choroidal detachment, and this is the hemorrhage egressing from the suprachoroidal space.
Okay.
So
this is a lucky placement, right? Because
but it is not.
it's beneficial
Sure, but it is
to
not.
drain some of the choroidals.
But it didn't drain all the choroidal.
Okay.
So I replaced the trocar again in a different place.
Okay.
And due to some of the hypotony and choroidal detachment in this place, it's, as we can see, it's hard to place the trocar. Yes.
Okay.
So I'm testing the passage of the light, so we can start the surgery and we're starting to do regular vitrectomy. And as we can see, there are multiple quadrants of choroidal detachment complicating this simple rhegmatogenous retinal detachment 1 week before he presented with such a complication.
Okay.
So we went for a regular vitrectomy, a core vitrectomy, and then shaving in the periphery. And
where was the break?
Superior temporal, over the area of the choroidal detachment.
Okay. So I've seen cases like this, and were managed with just injection of gas and then laser over the break. Since the choroidal, if the break is on just above the choroidal detachment, this acts like a buckle or a tamponade.
As suprachoroidal buckling nowadays.
Yes, and we could just inject air under local anesthesia or anything, and later on the retina flattens and do. I've never done it before, but I've seen other doctors do this, but I was never confronted with such a case where there's a choroidal just behind the break.
Another way to treat this, that you can inject a viscoelastic 1 day preoperative.
Yes, into the vitreous cavity.
Yes, into the vitreous cavity, so it will elevate the pressure and it will correct the choroidal detachment, so you can go for a buckle later on.
Do you always drain the choroidal detachments, or what's the cutoff point?
If it's hindering the way to
continue the surgery?
To repair this detachment, because the detachment and the tear is over this choroidal area, so I have to drain it as much as I can.
Okay.
And increase the pressure of the infusion to
45 or 60. Okay.
Mm-hmm. So and I have to keep an eye over the optic disc as well. Mm-hmm. So as we can see, this is a tear in the superior part, and I'm trying to drain the subretinal fluid to flatten the retina as much as I can.
Patient is on sedation, right? He's not
Yes.
on
Yeah, he's on sedation, and I injected a subtenon block, so it is not.
The patient is just moving his eye,
that's why I said. And that is because this is the main tear that he was presenting with in the first visit, and it was very simple to go for a scleral buckle, even a segmental buckle.
The choroid was drained, but not fully, right?
Yeah.
At the end of the surgery. Okay. So now you shifted back to fluid?
Yes, because there was still subretinal fluid and there was like a sleepage. So I'm trying to shift back.
Okay. Would PFC help in this case?
I think so, because draining from the main tear with this choroidal attachment, it could be more challenging. So I prefer to do like a posterior retinotomy.
You don't regularly do a posterior tomography, right?
No, I don't like it at all because in my hands it's complicated with some PVR and some traction, and it may be a source for recurrence. So after draining from this
But why
retinotomy,
didn't you choose to put PFC and drain from the peripheral break?
I think if I use the PFCL and there is still a residual of this choroidal detachment, there will be some of the subretinal fluid, and as you can see, it's extending now to the macula. So I'm afraid to leave some of this subretinal fluid, and this patient will not position on face down, so it may complicate with a retinal fold.
Okay. For me, I just don't mind in rhegmatogenous attachments if there is subretinal fluid at the end of surgery. Even if it's much, they usually go on to be fine, and nothing really happens. What I'm afraid here from is the higher incidence of PVR due to the presence of choroidal detachment.
I was prescribed Solubrad or
Yeah,
steroids
I
after
was going to
surgery.
ask you this
Yeah,
at the
yeah.
end of the case. So when he presented, how long do you give systemic steroids for before entering the
For one
surgery?
month and a gradual withdrawal of
No,
this.
I mean pre-operative. If the patient presented first with this
3 to 5 days.
3 to 5 days,
Yes.
and after 3 to 5 days, if it doesn't make any difference, do you just continue to go for surgery or
Yeah.
do you wait more?
If after 5 days it's still complicated with this hypotony and this choroidal attachment, I may inject the viscoelastic and I may operate the next day.
Okay. And did you leave the patient on what tamponade did you leave the patient
This was left on silicone,
on? Okay,
and then silicone oil
removed.
was removed.
So was there a silicone underfill? Because if there is a choroidal detachment and a massive choroidal detachment like this one,
I tend
there.
to inject it to the high intraocular pressure at the
Yes.
end of the surgery and suture all the sclerotins because of the fear of the underfill. And if it is an underfill, this is a superior
Yeah,
tear.
yeah.
So
I just if it's an inferior break and there's a choroidal detachment and you decide to put the patient on silicone oil, there is high incidence of silicone underfill and redetachment. But since this was a superior break, then this would go fine. I think even if there is some silicone underfill, it won't matter. But yes, I agree. Since there's this choroidal attachment, putting the patient on silicone oil for the fear of PVR is a wise decision. And also, this patient is not fit for another surgery.
yes,
Recently, he could have other health problems. So a second re-intervention may not be an option. So just put on silicone oil to be on the safe side and to try to solve this patient's problem as safely as possible. So this patient did well, right? And had
yes. After silicone oil removal, his vision is stable at zero point 0.2.
0.2.
I think this is probably due to poor perfusion due to his general
And
condition.
he was macula off for some time, right? You said around 10 days or something.
Yeah,
So
yeah.
this could explain the visual acuity. Would you consider the gas and the initial option that I told you in the next case this presents to you? If you have a similar case in the future and there's a break on the choroidal attachment, just inject gas and give it a try to laser the break and.
I could try because it is more conservative, and if it give a successful rate in some of the patients, yes.
I personally didn't do it, but I just giving
But
you an
it's a good
option.
thought, especially in the era of the suprachoroidal buckling for
Yeah, it
retina-angiomas
solves the
transplant.
hypotony
So
and
we
it
already
can
have a
solve.
buckle, yes.
Yeah, it solves the hypotony and it solves the retinal detachment. So we could give it a try maybe in the future.
So you inject a gas like a pneumatic retinopactor.
Yes, just gas. Without cry, just gas,
Mhm.
and position the patient to seal the break, and in a few days you can just laser the break, and that's
I
enough.
mean, like in the same concentration and volume,
Yes,
right?
point 0.3, about point 0.6 SF6
Yeah.
gas. And since the patient is hypotenuse, so we won't have a problem with high OAP, and it may solve the problem. Yeah.
Okay.
Okay. Thank you very much for watching. Hope you enjoyed this episode, and stay tuned for the next one. Thank
Thank
you.
you.